it's really important to acknowledge, I think, the work and the dedication that the health professionals who work here in New Zealand, the way that they work, their dedication for doing their jobs. And I think that as researchers, you know, as we work with clinicians in the hospital, which we do on a daily basis, seeing their passion, the skill and dedication, and the way they apply that to looking after their patients is really without fault. And so tonight's talk is about the potential that AI and precision health offers us all. It's the potential that it offers to the system, but there's a lot of hype sometimes about AI and about precision health. And it's our hope that through the talks tonight, you will actually come to understand the sort of measured discussions that are beginning to be had about the way that we do this, and those discussions are increasingly occurring across the country. So it's my pleasure now to introduce Chris Paton. And so Chris is an associate professor at the Liggins Institute in the Department of Epidemiology and Biostatistics here at the University of Auckland. His work focuses on how AI technology can be used to improve healthcare systems around the world. He's medically trained and also holds a DPhil from Oxford. Chris is the editor-in-chief of the BMJ's Digital Health and AI Journal, which is a new journal that's been dedicated to the application of health, or AI in health, sorry. He's also a member of the Health Systems Collaborative at the University of Oxford and is internationally recognized for the application of AI to health. So that's not my talk, I'll talk later, but I'd like to introduce Chris now. Chris.
Kia ora koutou. And so today I'm going to talk about using AI for improving healthcare delivery. I'm going to start off with a bit of an explainer about what artificial intelligence is. So I know some people in the audience will be experts on artificial intelligence, and some people just have heard it in the news and haven't really heard anything about it. So I'll just try and explain what it is to start with. And I'll give a few examples of my projects that I've been involved with over the last few years. And then we'll just finish about a couple of questions for the future of healthcare in this kind of AI age. So let's start with what is AI. So AI has actually been around, the term AI has been around for a long time, like many decades. And actually what we used to call AI is what we now call an expert system. And these are used widely. So for example, in the UK, in the NHS, they use an expert system behind a lot of the services they provide. So if you phone up the 111 helpline, the person behind on the phone will be using an expert system to guide you through, asking you what your symptoms are and what kind of help you need. And even they have a website where you can log on and put in your numbers. So what is an expert system? It's sometimes called good old-fashioned AI or GoFi, but it's basically a decision tree that's been produced by a computer programmer working together with an expert in an area. And in healthcare, that might be a doctor. And they go through, what should we put on the branches of the decision tree? We do if this, then that, and try and work out what you do. And in the end, you have this kind of almost intelligent type of system that you can use for helping people navigate healthcare. And if you go into hospital and they prescribe a drug for you, you might have an expert system in the background that checks that the new drug doesn't interact with the drug that you're already on, or if you're allergic to a drug. And so this is quite widely used in healthcare, but we don't really call this AI anymore, and we're much more interested in a new type of AI, which is what we call machine learning. And so this is where we get computers to try and learn relationships, really, between two things. So the example that we give for students who are learning about AI for the first time is often just a simple example about a simple relationship and how you can get a computer to learn that relationship. So the example we quite often use is house prices and floor area. So if you buy a house with a big floor area, it's likely to have a higher price than a house price with a smaller floor area. And when you're at primary school, you probably did this kind of exercise where you would take a few examples, and so in this case it'd be a few examples of houses that have sold, and you've got their floor area, and you might plot it on a graph like this. And then you'd get your ruler out, and then you'd draw a line through the points in the way that it looks like it fits best. And then you can then use that line to look up floor areas that you haven't got from your samples, and see what their price should be, and you can make a good estimate of what their prices would be. So basically, that's what we want computers to do in machine learning, this kind of simple learning exercise. But computers can't see, and they don't have rulers they can get out to do it, but they can do it using mathematics. So what they can do is, first of all, make just a random guess. They've got no idea what the relationship is, so they make a random guess of a line, and then they can measure how far away from all the points that line is, and then add up all those distances, and that gives them a number. And then they can make another guess, add up all the distances again, and if that distance is a bit less, they know that the line is going in the right direction. It's becoming more of a line of best fit. And it can just keep repeating doing that until it finds a line of best fit, and then it's found a relationship. So that's kind of at the basic level what a machine learning algorithm is really trying to do. But obviously, most things that we're interested in are more complicated than that. And we really want a computer to have more than just fitting one line to one other factor. We want it to have a bit of intelligence. And over the last few decades, there's been lots of different approaches to trying to do this for computers. But somebody had the bright idea of saying, we know it can be done because we know that there's intelligence in the world and it's in our own brains. So why don't we just try and copy how the brain works and then apply that in a simulation in a computer and just see if we can get artificial intelligence in that way. And so that's the idea behind deep learning, which is about creating artificial neural networks that are based on the same idea as how the neural networks in our own brains work. So by adding together lots of neurons in the same way that we have in our brain, we can create more complicated relationships between things and get computers to do more interesting and more intelligent things. So this photo here is of the first attempt at a neural network that worked by learning, making guesses and updating itself and learning in the same way. And it was actually a physical machine. And if you see the two bulbs, they're like eyes, and it was used to draw a line between points to try and classify one set of observations against another. And we still use a similar kind of approach. And when you have a deep learning neural network, what you're doing is taking lots of very simple relationship calculations and then adding them together into a network that enables you to do more complex relationships. So deep learning now is quite widely used. There's over 1,000 different AI systems that have been authorized by the FDA in the United States for use in healthcare. It's used for things like helping radiologists look at radiology films and working out what's wrong with patients. Also widely used in all of our smartphones and a lot of the technology we use on a daily basis. So this idea really took off and has been really a successful way of trying to find out how we can make computers more intelligent. So how far along that pathway are we? So probably the most advanced artificial neural net that's working at the moment that we're all using is ChatGPT. So hopefully everyone's had a chance to play with ChatGPT. And so ChatGPT is an artificial neural network, like the ones I've just described, based on this idea of the human brain. And it's got 16 billion neurons. So the equivalent of 16 billion of these machines that were invented in the 1950s, all put together to map out a complex equation. Those neurons are connected to each other with 1.5 trillion connections. And then it took about 3 months to initially train it. The latest version, well, there was a new version came out a few days ago, but the version behind that, ChatGPT 4, took about 3 months to train and then 3 months to kind of keep working on until it was ready. But it doesn't learn, and there's only about 2,000 or 3,000 of them out there on the internet that everyone's interacting with on ChatGPT. So the brain, on the other hand, this is a picture of a neuron. So this was the first description of a neuron that was done but when the microscope was invented and they started looking at lots of things under the microscope. So this was a hand-drawn neuron by Camillo Golgi. And you can see from that there's interesting structure, isn't there? So at one side of it, there's all these millions of branches, and then there's one axon coming out on the other side. So in our brains, we've got about 100 billion neurons of these things, and each one of them can connect to about 10,000 other neurons. And so that makes about 500 to a quadrillion connections. So we've got more neurons and more connections than ChatGPT, so we're doing pretty well. And we've evolved this over about 600 million years, which from when the first neurons first started to appear in animals. Whereas ChatGPT trained in 3 to 6 months, which is, they're probably winning on that front, I would say. But we can learn. So ChatGPT can't learn. It's a fixed model. It's not, when you put stuff into it, it's not learning and updating. They have to release a new model to make improvements, whereas we obviously learn over a lifetime. And there's also 8 billion of us, which is quite good. So we outnumber them as well. So the question really is, how do large language models, which is the neural network structure behind ChatGPT, how does that work? So like I said, it's a deep learning artificial neural network. And instead of being trained on floor area and house prices, it's trained on sampling sentences from Wikipedia and other sources of text on the internet. So it would take a sentence and it would hide the last word in the sentence. So the sentence might be, a dog is a kind of mammal. So it would hide the word mammal and say to it, if I give you the sentence, a dog is a kind of, guess what the next word is going to be. And if it says mammal, then it gives it a thumbs up. And if it says something else, then it gives it a thumbs down. And then it gradually updates and tries to get better at predicting what the next word is. And then you can use that simple kind of prediction to answer questions. So if your sentence, instead of a dog is a kind of, is a question, then the first word that it predicts is the first word of the answer. And then it can keep predicting words that make up the answer. And also, which I'll talk about in a minute, can also be used for summarizing consultations with doctors, which is quite a nice use case. However, there is a bit of a problem. Predicting, you can imagine, you can kind of work out how you could get from floor area to house prices by multiplying the floor area by the house price. But what do you multiply the start of a sentence by in order to get the next word? It seems a bit mystical, doesn't it? But there is actually a shortcut to doing this. If you think about the amount of text in Wikipedia, you can probably download it onto a thumb drive. It's probably about 2 or 3 gigabytes of text. And these new models that they've created are probably 5 or 6 gigabytes in size. So if you give the model enough space just to store all of what we call the training data, then the model's, the easiest way to predict the next word isn't to work out a complex calculation about how the beginning sentence ends up with the next one. It's just to memorize all the words and look up the answer in its database. So this actually works quite well for ChatGPT, because what we really want is just to search things like Wikipedia and get easy answers from Wikipedia. But the problem is, if the next word in the sentence wasn't in Wikipedia, then it has to make something up, and that's where we get this thing of hallucinations. So most people who've used ChatGPT over the years have found out that sometimes it just makes up the answer confidently, and that's a little bit of a worry. There's been a whole load of research papers published saying that ChatGPT is as good as a doctor because it's passed the licensing exam. So there's a licensing exam for the US called the US Medical Licensing Exam, and ChatGPT is really good at answering. It gets like 80 or 90% when you put the questions in, and it answers them. But the problem is that the questions for the USMLE, there's lots of practice questions for medical students on the internet, and it's quite plausible that when they trained ChatGPT, they downloaded all of the questions with the answers, and it's doing the same thing of just looking up the answer rather than working out this kind of complex relationship. So we were all quite excited about it. That's a bit disappointing, but there is a bit of a twist, and that is that even larger models may develop new abilities. So this is a graph that was produced by OpenAI, who made ChatGPT before it all started to get very popular. And they show the problem that I was talking about. You start off with a very small model, and it doesn't do very well. So if you have the house prices, so if you just have the floor area, it's not going to do a particularly good prediction of how much the house is going to sell for. But if you add on another factor, like how far away from the CPD is it, how close to the beach is it, what kind of style of house it is, it starts to get better at predicting. And that's the beginning of this curve as it goes down from having 1 or 2 parameters to going more and more. But eventually you get to a point where everything that could go into house prices and make a good prediction is accounted for in the model, and the model's reached its kind of optimal size, And that's the bottom bit of this curve where you've reached the minimal amount of error that you're going to get out of doing a machine learning algorithm. And then when you start making the model bigger, that's when it starts doing this memorization. It starts memorizing the examples of house prices that you've put in, and then that causes it to make errors. But the twist is, as you get even bigger, it starts to come down again, which is quite an interesting feature. And we didn't really know about this until we started to do very big machine learning models. So we always thought that there's this optimum model size for everything, and that's what we want to reach. And we don't want to make it too big because it will just start memorizing the data and overfitting, which is not what we want. But the theory behind ChatGPT isn't that it's memorized the internet. It's that it's memorized the internet, and then it's using that to then work out what people are saying on what they're talking about on the internet, so it can start to do things like reasoning and thinking and becoming more like a human brain. And that's what the kind of excitement is about. But it's all still fairly speculative about how far along that curve we are. And the other thing to notice about this is it's not like the beginning drop in error. The error is slowing down, and as the model gets bigger, you have to make really, really, really big models. So the question is, how big do the models have to be before we get really good levels of intelligence? Okay, so I'll take a break from that, and I'll tell you a little bit about some of the projects that I've been involved in over the last few years. So this is really using deep learning neural networks for trying to improve healthcare services. So this first project is based in Kenya, and it's using some technology that was developed by a friend of mine, Mauro, from the Department of Engineering Science at the University of Oxford. And so he developed this technology for looking after newborn babies in the hospital in Oxford. So if a baby's born very prematurely, their skin is quite thin and fragile. And so if you want to monitor the baby's heart rate and the breathing rate, sticking on sensors like we traditionally do can damage the skin when you take them off, and especially if you're having to take them off regularly. So he developed technology uses a camera that sits above the cot and uses the changes in the color of the skin as the blood pulses through the body and the changes in the movement of the chest to work out what the respiratory rate is and what the pulse is of the baby, which can then be used for the doctors to make decisions. So what we wanted to do is take that technology, see if we could use a smartphone camera and take it to a use case in Kenya. So working with Ambrose, who's a pediatrician in Kenya, we wanted to use this technology to help healthcare workers in very remote settings make a critical decision, which is if there's a child who they suspect has got pneumonia, can they treat them with antibiotics and just give them some antibiotics and let them go on their way, or do they need to be admitted to the hospital in the city, which can be quite an expensive and dangerous thing to do. And so using the technology that's developed at Oxford, we've been recording videos of patients and children in rural Kenya to develop an algorithm that can help these healthcare workers decide whether or not children need to go to hospital. Another project we've been involved in is in Vietnam. And the challenge there is that they're building lots of intensive care units across the country, and they're using respiratory ventilators for ventilating sick patients if they've had a big operation or if they're very sick. But the problem is equipping out those ICUs with all the kind of technologies that we have in New Zealand or other high-income countries is very expensive, and it's also quite difficult just to source the actual equipment and to maintain it to a good standard as well. So teams from several universities have been getting together to think about how can we use AI in different areas to help in intensive care units in Vietnam. So some of the ideas that we've been testing and trialing out are, instead of having very complex screens with lots of information on, just having a risk score that basically tells the nurse when they need to contact the doctor to come and have a look at the patient because they think they're deteriorating. Another example is helping people to do ultrasound scans on the wards. So one of the things that you often do with patients when they're very sick is use an ultrasound scan to see what their heart's doing, how their heart's pumping. But you need to have some level of training and skill to do that. So one of the teams developed an AI system that could guide the practitioner how to do the ultrasound scan as they were doing it. It would tell them it was pointing in the right direction and that kind of thing. And that just enables people with less training to be able to do similar kind of jobs that required more highly trained people in the future. And so our team from Oxford, which I was involved with, was involved in thinking about how we take these AI innovations and make sure that they're actually going to work when they're employed in the hospital. So we did things like having researchers who would sit in intensive care units and make notes about what everyone's doing, and then interview all the nurses and the doctors to find out what the real problems they're having are, and just making sure that when we're developing new technologies, we're actually solving real problems that the clinicians have got on the wards. Okay, the next project is we initially developed it to train healthcare workers in Kenya, particularly around neonatal resuscitation. So this is a virtual reality simulator that you put on a headset. It's one of my colleagues at Oxford, you can go in and you can practice resuscitating a newborn baby. So the baby's been born, you're told the baby's born and it's not breathing. So what have you got to do? And so you have to go and walk over, pick up the right bits of equipment, and then do the right series of steps in order to get the baby breathing again. And so now we want to take this project, and for all of the characters that you can kind of see in the background, we're going to infuse them with AI systems so they act more like real people, and they can go about their jobs on the wards in a realistic way. And then we're going to use this as a simulator for experimenting with how things can be done on wards. For example, you could have a ward that is a normal ward, that the pandemic has come and you need to convert it to a respiratory ward. So you rearrange everything and then you see how the AI agents all go about their business and find out how many staff do you need, what kind of equipment do you need, how long is it going to take to do things. We're also thinking of using it for climate emergencies. So if a power is knocked out in a storm, how do you move the hospital over to using non-electrical equipment and testing that out, and also using it for more advanced training. The other idea that we have for it is to use it for generating data to train AI systems. So with the Tesla self-driving car, they use a similar type of simulation for training the self-driving AI system. So they don't just use data from the real world, they also put their cars into a computer game and test it out in a virtual world. So we can do the same with this technology. Okay, so to finish up, I just wanted to talk about how these large language models like ChatGPT are currently being used in healthcare. So you've probably been to your GP recently, and some people might have seen a sign on the wall saying, we're now using AI in the surgery. And what they're using AI for is recording the medical notes. So it's called ambient AI scribing. And it's where we use a large language model to listen to the consultation the doctor's having with the patient and then summarize it and then put it in the GP's notes for them. So they might have an app on their phone, or they might have a website that they go to, and you go into the consultation, they press record the consultation that they're having with the doctor, and then they send the recording up to the cloud, and an AI system turns it into a note, and then they send that note to a large language model, either the ChatGPT model or a similar model from another company, which then summarizes that note into something that they can then cut and paste into the medical record. And some of the medical record systems now are automating this and integrating it so they don't need to cut and paste anymore. And it's estimated that probably about 50% of GPs in places like New Zealand are now using this technology. This is a question that we get asked all the time. So is ChatGPT a good doctor? So if you put your medical question into ChatGPT, is it as good as is it as good as going to your medical doctor? So this was a study that came out that they tested this hypothesis. So they got, there's a web forum where doctors volunteer their time and they answer questions for patients who post messages on the forum. So they took the questions from the patients and they pasted them into ChatGPT, and then they compared the answers that ChatGPT gave to the answers that the real doctors on the forum gave, and they gave them ratings. And in this study, they said that the chatbot responses were rated higher for quality and empathy. So they were nicer to the patients, as well as being more accurate. Now, I think this is an example of the type of research that's been going on to date. It's quite a small study, and if you think about it for a minute, you realize that it's probably not that reliable, because if people were trying to assess the difference between those two things, you probably work out fairly quickly which one was generated by ChatGPT. It's got a style, and it's very long, and it's all polite and nice. Whereas these doctors posting on the forum in their spare time just post quick answers, and it would be fairly obvious which one's which. but it kind of shows that people were surprised how well it did. I think that's probably the message from this study. And then we've got to remember that even if it's getting better and even if it's getting really good, is it actually what patients want? And so this is a nice story from the San Francisco Standard where the nurses went on strike because of AI. And they said that we shouldn't be replacing nurses with AI systems because computers are not the same as humans and it's not what patients actually want. So we're not solving, going back to this idea in Vietnam, we're not solving the problem that patients want us to solve. So you can't hold a loved one's hand, you can't teach a computer how to have empathy. But the other big problem is this one of hallucinations that I was talking about earlier. So if a ChatGPT is making up something and it doesn't really matter that much. So say you ask ChatGPT which restaurant should you go to in Auckland this evening, and it makes up a restaurant that doesn't exist. It's going to be a bit annoying. You'll go to the restaurant, it won't exist, and then you'll quickly realize, oh, it's a hallucination. Let's try again, let's use Google or something else. But if you put in a medical question and it hallucinates something, that's another thing altogether, isn't it? That might be quite a disaster. You might decide not to go to hospital, or you might start taking a medication that you shouldn't take. And there was a nice story in Washington Post about a year or so ago that illustrated this. The doctor had an AI system there using quite a recent model, so the model just previous to GPT-5, and they said, when I'm eating a tomato, my lips get swollen up. And it said, oh, you've got tomato allergy. Some advice is stop eating tomatoes, which everyone agrees with. But then it said, use a steroid cream to reduce the inflammation on your lips. And then the doctor that they went to see said, oh, no, you shouldn't do that. Because your lips are quite thin compared to the rest of your skin. And if you put steroid cream on it, it can be quite bad. So you can get quite a bad reaction. And so that's not good medical advice. And you can imagine that there's lots of examples like this. It's got nothing to do with Ariana Grande. The other problem is that health AI is expensive. So these computers that run AI systems are extremely expensive. I was just looking at buying a new AI computer, which I haven't talked to Justin about yet. But I gave some specifications for the health simulator platform, and it suggested a nice system, which I went to look up. And then I asked ChatGPT how much it costs, and it costs $500,000. So these computers are expensive, and when you type into ChatGPT, you're burning a lot of money. So companies like OpenAI are going through billions and billions of dollars. And what you get for that money is you get less hallucinations. So it's a bit of a dilemma, isn't it? If you're asking a healthcare question, so this is the graph of GPT-5, which just came out, versus GPT-4, which is what everyone's been using up until now. And for hard, challenging healthcare conversations, this is ChatGPT's own research. They've gone from 15% of the time making things up to 1.6% of the time. So if I was asking a question, I'd really want to use the new models, but then I'm currently on the Plus subscription, which is $20 a month. So it sometimes gives me the new model for that. But if I want it all the time, I've got to pay $200 US a month, which is like 350 New Zealand dollars, which I don't think I'm going to be able to justify, really. So there's an inequity there that might be getting worse as the models get better and more expensive. So the other thing is about trust. And what we are worried about with AI is when you send data into an AI system, do you trust the company to look after your data? And for most things, that doesn't matter. For some things, it matters a lot. So for healthcare, I think it matters a lot. And there was a survey by the NHS that said, do you trust an AI system and with your data? And they said, we trust the NHS to look after our data, but we don't necessarily trust an AI system. So how do we get over that? So one way of doing it is by downloading the AI onto your own computer. And that, from what I've just said about the expense of it, that seems unlikely. But we were able to build a prototype system that uses open source AI systems that actually do the same job as the medical scribes that send the data over the internet to AI companies. So there is it's feasible now for places like hospitals to invest in AI systems that can keep the data secure on the servers. And we tested this just with using a video from the internet with a consultation, and it shows it how it can listen to the audio of the consultation using, this is a open source, freely available, downloaded AI system. can start to listen to consultations, transcribe them, and then turn them into a medical note.
Would you prefer Miss Melanie or would you?
So I won't go through the whole video, but it just starts recording it. The flashing lights are the CPUs. So this was on my new laptop, which is quite good, but it was really pushing the performance of the laptop in order to do it. So when are we going to get good quality AI doctors that we can rely on, that don't hallucinate and that are cheap? So this meme was from 2024, and I've updated it to 2025 because it's still true. So Elon Musk said self-driving cars in 2 years in 2015. This is the godfather of AI. So this guy invented deep learning with his PhD students. He said radiologists will be obsolete in 5 years in 2016, but radiologists still driving in regular cars to work. So I think there's lots of benefits to AI. It's going to be amazing for healthcare, but there's lots of risks and lots of challenges. And it's not just for clinicians and researchers to think about these risks, it's everybody. So when you make a decision about, do you want your data being sent to an AI company or not, you need to get involved in this. And governments have got a role to play. So we've been talking to governments, we've set up the journal that Justin was talking about a minute ago, and we're trying to generate good evidence. We want good quality studies that are reliable, that tell us when these systems are safe. We want to know what they're doing with the data, making sure they're storing the data safely, and then we can start using them in a way that's going to work. So thanks very much.
So it's my turn to talk to you now, and I'm going to talk to you a little bit, not about a $500,000 computer. Chris is going to have to talk to other people about that. We'll talk to you tonight about how we're applying some of those things that Chris talked about into healthcare, and how we're doing the research that's leading that so that we can bring it in New Zealand to help here. So the Liggins Institute, our goal is a healthy start for a healthy life. This is what we try to do. We work with children, mothers, babies, and the goal is really to help with the things that impact during the early life events and really help kids live a long time. And so this is personal. It's personal for all of the people that do the work, and it's personal for the people that we are doing it with. And a lot of the projects that we work on, and not just the ones I'm going to talk about tonight, but projects that have been led by Jane Harding and Frank Bloomfield and others, they're working on precision nutrition, other ways of doing precision health that are really helping and having fantastic outcomes. It goes all the way back to the sort of ideas about using steroids for inflation of lungs, etc. But there are a lot of myths about precision health. Now, Chris has talked a little bit about some of them, and we can go through those here. So that it's only relevant if you have a rare inherited condition. Well, that's simply not true. Precision health is a particularly important thing. It's important for common diseases that have complex genetic etiologies, and it's particularly helpful for those as well. It's all about the DNA because genes determine everything. Well, this statement is just fundamentally wrong on so many levels. Genes don't determine anything, they're probabilistic, right? It's an outcome, it's an opportunity, it's not your future. And precision health has been around for a long time. The 1900s, when your blood antigens were first discovered, the use of that information in blood transfusions, organ transplants, all of these things are precision health. In fact, some people would argue that the DNA and the use of DNA and the focus on that has actually slowed down the development of precision health. They might be right. The precision health delivers instant answers. One test, you know exactly what to do. Well, look, no, that's not true either. The findings require really careful interpretation. There's ongoing monitoring, there's integration. You have to work with clinical people to really understand what's going on. We have cases we've been working on, and others have cases we've been working on for years, trying to understand what's actually going on. It's not a straightforward one-test answer. AI and big data will replace doctors with algorithms. Well, I think Chris has just answered that one for you. And precision health is only for wealthy individuals or countries. Again, Chris was talking about the costs, and the initial costs can be high, right? Targeted interventions, depending on how you do them, they do cost money. Many people will argue that precision health and the application is going to save the health system money. The reality of that is it's not really. It's going to cost at the beginning because we need to, and it will help extend well-being for people. But most of the money that's spent on health is spent in your last years of your life trying to extend that and trying to look after people. That cost is not going to go away just because we have precision health. So, how are we moving from genomic narratives to newborn futures? And that's the question. So we have started out, and we're starting with baby steps. So in New Zealand, there are about 5 deaths for every 1,000 live births in the country. One of those occurs in intensive care and is associated typically with undiagnosed genetic disorder. These are little generalizations, right? So you have to bear with me with the stats, but that's pretty bad, okay? What we've been doing, and we've been working with the hospital over the road, was trying to work out how we could help with that. And what we were doing was we were playing spot the difference. We were sequencing the child and getting their DNA sequence, sequencing the mum, getting hers, and sequencing the dad and getting his. And then you just play spot the difference with the DNA sequence. Well, you use the computer to do that, right? But the simple illustration is here, right? So we've got mum here, we've got dad. I know dad's got others. And dad's not a dad. Well, I grew up in a city. So if we take that, okay, and we run across, and of course the child here doesn't have the spot, right? That's exactly what we do with the DNA sequence. It's that simple. But then we use Bayesian AI systems, like some of the ones that Chris was talking about, to run through all the literature that's been published about everything that we know. And it helps us identify those genetic changes where in fact they're associated with a genetic condition or a predisposition for a condition. And that information we then feed back to the clinicians, and they use that as a part of their decision-making process with all of the experience that they already have. So they contextualize that information, and then they act on that as they see as appropriate, which is amazing. To date, we've actually done about 25 cases now, but we had a 70% diagnostic rate, which is really, really good. Okay, so 70% of the time we find what we think is a very, very relevant information for the reason why that child is in intensive care. So that's great, and these are the people. It's a very big project. This is just one example, and I'll show it very quickly. What you want to see when you look at the DNA like this is effectively you want to see this, right? This is a lovely match, okay, for both the son and the mum here, back to our reference sequence, right? There's a reference sequence of DNA. There's references for everything. Okay, so we have a reference sequence, and this matches beautifully. This piece here doesn't match, okay? Both mum and the child have got a deletion in that region of this gene. And that, on its own, would be fine. Unfortunately, this is dad's sequence, same gene, different spot, but dad has a mutation here, just a single mutation, and it only occurs in half of dad's sequences, 1 chromosome. Here, the son has a mutation as well, unfortunately, in half of their chromosomes. That means that the son has 2 mutations in the same gene. That means that both copies of their gene don't work, which in this case, because the gene is this one called, it's actually called GBA, but that doesn't matter, but this causes a disease which is called Gaucher's disease, where you have liver problems, mental issues, development problems and stuff. And so that means that unfortunately this child, who's got the broken copy inherited from mum and a broken copy inherited from dad, basically, well, not basically, they had no functioning gene, okay? That's bad, but knowing it is good because you can do enzyme replacement and you can give the child the enzyme and that helps them with their life. So that's great. Is it fast? Speed in these instances is really important because developmental conditions, you actually accumulate damage. The more you accumulate, the worse it is when you stop it. Speed is critical. Here, we get results normally within 48 to 96 hours, and we get those back, so going from bed back to the clinicians is normally less than 5 days. And that's pretty good. So that's a real help. We find things that we don't expect. So in this particular individual here, they had a mutation in this gene, which is called VIPAS39, which doesn't mean anything to anybody here. But basically what it does is it means that you get variable manifestations. You get changes in the gut, in the development of the gut. You get changes across other places as well. But the gut malformations are really important. So we found this But when we looked in the blood of this individual, we also found all of these sequences. Now, these sequences are all from bacteria. They are from the child's gut microbiome. And what we think is happening in this particular instance is that that particular gene, where they had a mutation, it caused a malformation in the gut, and somehow there was a connection between the gut and the bloodstream, and the child had a complete microbiome floating around in their blood. This is not a contamination issue. This is a real finding. So that's particularly important. But there must be other applications, right? We can do this fast. It doesn't take so long. In fact, the machine that we use, I would have brought one down, but Eric would tell me off. It's about the size of this, right? Literally. We can take that machine, we can do other things with it. And one of the things we do with it is this. And this is here, this is an actual preparation going through. The video takes about a minute. I won't stay on the slides that long, but what we do here is in less than 3 hours from getting a piece of tissue from a brain, we can tell you what type of tumor you have, okay? In less than 3 hours. And this is particularly important. Brain operations, brain tumors, they're inside your skull. It's pretty well protected. It's difficult to get to. Samples are taken during operations. They are sent down histopathologists. They run through them, they look at them, they classify those tumors on a microscope, and they are really good at it. But here, we can move away from a qualitative assessment to a quantitative assessment in less than 3 hours. The next day, we'll actually tell you the exact mutation, not just the type of tumor, not just if it's aggressive or non-aggressive, but the type of mutation and the exact treatments that you can do on top of that. 3 hours, all for a couple of grand. That's really pretty cool. We've done it. We've done about 20 times, and Dennis is doing this work. So done it about 20 times, and it works perfectly. So what we're doing now with Clinton Turner, Brain Tumour Support New Zealand, we're trying to set up a trial to actually do this in situ so that it's running during an operation in the hospital, just as the histopathologists work. What about rare diseases in the community? We're also applying this there. We've done less rare diseases in the community. Rare diseases in the community are a bit harder to diagnose. We only have about a 30% diagnostic rate for the ones that we've done so far. The reason for that is that they're not as acute, right? They're not as immediate. So the differences and the difficulties in understanding what they're actually doing. But we're getting better with that as well, and that's cool. But one of the things that we really worry about is the idea that we can find out what these things are, and I can tell you, I could sequence people here and tell you have mutations for this or mutations for that. It's not that difficult. Knowing is good, but it's not enough, right? It's one thing to know, but so what? So we want to move away from treating the average Kiwi. That's supposed to be Fred Dagg, for those of you who know. Treating the average Kiwi for the most common causes of death, disability, okay, and illness. And these are, heart attacks and diabetes, these sorts of things. We want to move away from that. We want to treat people as individuals, because you are. So we're doing this. So this is Katrina, and she's doing this, which is basically playing 3D chess. This is, I think, something from Star Trek originally. We don't play it with chess pieces. What we do is we take 9,000 different phenotypes. Phenotypes are descriptions of you. They're descriptions of your body, of how big your blood cells are, all those types of things. We take those phenotypes and we connect them to the proteins that are known to work with those phenotypes or contribute to those phenotypes. And there's about 27,000 of those. Different connections, lots of different connections. And then we say, cool, we've got a lot of drugs. The FDA has approved a lot of drugs over the years. In fact, it's not 80, it's 8,000. 8,000 drugs have been approved by the FDA. And these drugs have all been used. Many have side effects. We know what those side effects are. Those side effects affect particular proteins. They affect particular conditions. By doing this, we effectively connect the FDA drugs to the proteins. The proteins, of course, are connected to the phenotypes, which means that what we can do in minutes is go from here to here, or from here to here, if we have the information on the phenotype, when we want a drug, we can put that in, and it will say, try this. And it will tell us why we should try that drug, based on all the literature that we have. Or, if we have the gene, we can put the gene in. When I say we, Katrina can. Put the gene in, and it will say, use this drug, and it will treat these phenotypes. And this is really powerful, right? These drugs are all licensed by the FDA. They exist. We know what side effects they have. It's really cool. But doing that in and of itself is great, because it means we can be more targeted when we treat people, or when clinicians treat people, because we don't. But we could be more targeted. The only problem is we don't really want to experiment on people, right? It's a bit difficult getting them to agree. So what we're doing here is we are creating twins, digital twins. And so Katrina has this running now, and it's pretty good, but it's not good enough yet. The error is about half a deviation, as she was telling me today, half a standard deviation for the prediction. But basically what we do is we're taking these kids that we have, where we've worked on in Bangladesh, and basically we know they were malnourished, and so we put them through an intervention to try and recover their bodies and their minds and things as a result of the nutrition. So we were trying to optimize that for their recovery. As a result of that, we got a lot of measures on these children, and so we can create digital twins from them. We have their genetics, we have all their bloods, etc. So what this does is it lets us actually run what-if scenarios in silico. So in the computer and in the model that Katrina is building up now, we can basically tweak different features. And by tweaking those features, you can see the long-term outcome of that over a trajectory, which means that you don't have to experiment with people because we have it in the models in the computer. And these models aren't perfect yet, but we're starting here with the malnourished kids. We're trying to optimize their recovery and the recovery of their brains, because that is particularly important. Brains don't just recover after malnutrition if you just give people food. That's not how it works, unfortunately. So the digital copies of ourselves will help immediately, and they'll help with rare diseases. About 5% of us, the births in New Zealand, that are affected by rare disease with a genetic basis, which is a lot of kids every year. They'll also help with the reported adverse drug events that occur. There's about 4,000 of those. It's only estimated to be about 10% of the ones that actually occur. And they will really help us, all of us, including people that don't have rare conditions eventually, when we make them, because it'll let us move away from an ambulance at the bottom of a cliff, really to a system where we are targeting disease prevention. And that's the key, because the genes tell you risk. That's a risk for something that might develop. And as long as you're understanding that it's a risk of something that might develop and it's a probability, it means that you can do things that will reduce that risk over time. And that has huge impact for people. Now, we might get it, we'll start out, so I use ChatGPT to do this. So we'll start out creating digital pictures, and we might get it a little wrong. Yeah, although I'm not sure if my wife prefers that one or my one, actually. So I might have got it right. But look, we'll get it a little wrong, bit wonky to start, and that's fair enough. But it will make a big difference. It will happen over time. And precision health, it really does offer that opportunity to improve not just individuals with rare conditions, but everybody's health in the country over time. And that opportunity spans lifetime. It's from acute illness to chronic illnesses and diseases, and it's from prevention to really this personalised treatment across the lifespan. So I just want to thank all of these people who do all of the work. Like the ChatGPT, I'm just a pretty face. And here, the people that do the fund us as well, which is the Dines Family Trust, the Keller Trust, and Peter Gibson by the Tautoko Trust. So I'll thank them. It's now my pleasure to introduce Roan. So Roan is a postdoctoral researcher here at the Liggins Institute. She has a bioinformatics master's from the University of Glasgow, and she did her PhD here at Auckland with us. Roan is investigating regulatory elements in the control of gene expression and respiratory disease and the multimorbidities that are associated with that. And she's going to talk to us tonight about COPD. And so this is really exciting work that she's been doing, and so please join me in welcoming Roan.
Good evening, everyone. It's such a pleasure to be showing you some of the work that we've been doing around the prediction of risk for COPD, or chronic obstructive pulmonary disease. So just a disclaimer, I'm about to show a video of human lungs. So if you're a bit squeamish, maybe now is the time to look away.
And you can see so inspiration, expiration, they totally deflate. And they're right back to where they were before we started. It does a little bit with the peak, but it's not quite as impressive. Because these lungs are COPD lungs, cancerous lungs, the elastance is gone, so they'll stretch out, but then the recoil of them just snaps right back because there's nothing to help hold them open. So you can see there how fast they deflate.
So that's COPD for you. The reason COPD develops in some individuals, but not others, is, well, there are quite a few risk factors. The highest risk factor is, in fact, smoking, which explains the color of the lungs here. But there are also some other risk factors for COPD, such as exposure to certain environmental pollutants, but also genetic risk. And it's actually quite surprising that COPD, or chronic obstructive pulmonary disease, is the 4th leading cause of death worldwide. So currently, the way we diagnose COPD is through this breathing test, or spirometry test, that essentially measures how much air your lung is able to expel. The problem is, if you've been diagnosed with COPD, your lungs are already not functioning well, so it's kind of a bit too little, too late. So naturally, we ask the question, are we able to identify or predict COPD development before it does damage to the lungs? And we wanted to do this in a personalized way. So by looking at 3 factors, for each individual, are we better able to predict their risk of developing COPD before the damage happens? The first variable that we've looked at is genetic risk. How much genetic risk do you have to develop COPD? The second is through CT scans of each individual. So if you physically look at the lungs, are you able to predict or to see the COPD in the lungs? And thirdly is clinical risk. So this will include things such as how old that individual is, how much do they smoke, are they male, are they female? So these are the 3 variables that I'm using in my prediction of COPD. Where do we get these individuals from? That's where cohorts such as COPD gene come into play. COPD gene is a cohort of more than 10,000 individuals that smoke. 5,000 of them have COPD. The other 5,000 don't have COPD. And we have everything we need to know about these 10,000 individuals. So I have their DNA, so their genetic data, I have their CT scans, and I also have their clinical risk information. But how do you actually quantify genetic risk? So if you were to look at our DNA, we have these positions or genetic variants that make some of us at higher risk of developing COPD compared to others. Now, the vast majority of us don't have a lot of these variants. And most of us actually fall somewhere here in this distribution. However, there are some of us that have a higher than expected number of these variants, and so they are at higher genetic risk of developing COPD. And some others that have a lower than expected number of these genetic variants, meaning they are almost protected genetically from developing COPD. Genetically, but not environmentally. These are 2 different things. So just to give you an idea, in my machine learning model, I'm using more than 2.4 million of these variants to be able to quantify an individual's genetic risk. So essentially, I'm just counting how many variants they have. Right, the second piece of information or data that I'm looking at is CT scans. And this is work that has been done by the Auckland Bioengineering Institute. So if you were to look at a CT scan for someone that has COPD versus someone who does not have COPD, you can see that the healthy individual, their lungs are a lot more uniform, whereas the COPD individual, their lung is a bit more variable. So they have a lot more heterogeneity, which makes sense because some parts of their lung would be damaged, whereas some parts would be not as damaged. So this is another variable that I've used in my machine learning model, which essentially is a measure of how much heterogeneity there is in the individual's lung. Right, so these are my three models for you: my imaging model, my genetic model, and my clinical risk model. So for my clinical risk model, I have 4 variables that I'm looking at. That's age, how much do they smoke, their height, are they male or are they female. So these are 4 variables here, and about another 4 or 5 variables here that are specific to genetics, and another 4 variables here that are specific to imaging. So altogether, these are 12 different variables. Now, 12 is not a big number, but we are dealing with 10,000 individuals, so pretty quickly, you now have 120,000 different variables to look at. And that's just where our brains are not able to comprehend this much data. So that's where machine learning comes into play. How do you build a machine learning model? The first or most important step is to train your model. So you would give it all this data, and in the training step, the machine learning model would be able to pick up on patterns that are specific to people that have COPD and patterns that are specific to people that don't have COPD. The second step is to test your model. So now you would ask it, right, now you have all of this information, are you able to predict who's going to have COPD and who does not have COPD? If I was interested in the performance of these individual models separately, I could have stopped here. But I want to know, does adding all these 3 pieces of information improve my predictive ability for COPD? And so I combine all the models together. And we call this an ensemble model. And essentially, I will retrain the model, but now giving it all these 3 pieces of information and seeing and testing how well does it predict COPD. So you are all now experts in machine learning, pretty much. Right, so how does the predictions work? So in terms of clinical risk, in this plot you can see, for instance, with age, the model is able, or the model is telling us that people that are older are more likely to end up developing COPD, whereas the people that are younger are less likely to end up developing COPD, or they're less likely to be predicted to have COPD. Same as here, the model is telling us the more heterogeneity there is in the lung CT scan images, the more likely that you will be predicted to have COPD. And it's also telling us with the genetics, the higher genetic risk you have, the more likely you will be predicted to have COPD. So this aligns with what we would expect. Right, so what about numbers? Let's talk numbers. How well are these models performing? So imaging, just imaging on its own, is able to, or it has a predictive ability of about 81%. Clinical risk on its own is able to predict COPD with a rate of about 76%, and genetic risk is about 66%. What happens when you combine all these models? You get a predictive ability of about 86%, which is pretty impressive, if I should say so myself. I know I'm a bit biased. I've built the model, but still I think it's quite impressive. Okay, so then what? So far, you've seen how we're able to identify who has COPD and who doesn't have COPD. Ideally, we want to be able to predict COPD in the future. And what I haven't told you about the COPD gene cohort is that it actually it's longitudinal. So I have data of everyone at baseline, and I also have data about everyone 5 years later. So the question is my model able to predict who ends up developing COPD 5 years into the future or not? The second thing that we need to do is to consider the enormous number of CT scans that are already available to us. So in the US alone, there are more than 70 million CT scans, just CT scans done. So that's a big resource that we could use into predicting or using it to predict COPD. And lastly, because it's not really feasible or cost effective to stick everyone in a CT scan, it would be quite great if we were able to identify biomarkers, ideally something in the blood that's able to reflect how much heterogeneity there is in someone's lung. Thank you so much.